Today I have a difficult task because indeed I don't want to overlap to the other speakers, but at the same time I would like to give you some general consideration concerning the difficulties that we may have in making predictions and diagnoses. Our background started since the 60s, where Auersbach had just classified the ARDS as something that is refractory to the supplemental oxygen. And at that time, some amount of PEEP could just improve the general situations. And linking that picture to the autopsies with a general inflammation, edema, and the presence of hyaline membrane. And over the last 25 years, if not 30 years, there were different definitions that just overlap one each other. One I'm referring to initially is the consensus conference on the American European Consensus Conference that launched in 1994 this NEDUM definition. The starting point, but it is evident that causes some difficulties for the diagnosis, is that what really histologically characterizes the alveolar damage is indeed the presence of specific alteration of the membranes, the invasion of leukocytes, the alteration of the capillaries that are represented by the diffuse alveolar damage. But obviously, basing upon a biopsy, the diagnosis is not very practical. I want just to give you a couple of examples, just to stress how have been made several attempts in order to identify risk factors. For example, this one is an American study that focused on patients who had sepsis. And in multivariate analysis, for example, what emerged was the higher severity score, liver cirrhosis, metastatic cancer, as you can see, all very generical. And in different contexts, in a large population of trauma patients, at the end, also here, there were some predictors, and the presence of the ARDS was correlated to the increased mortality. This is the definition I was alluding to, the classical one that was fixed in the 1994. And as you can see, timing, oxygenation, chest radiograph, and the presence of normal, so-called, pulmonary artery wedge pressure represented the fundamental criteria to look at. However, if we think about how limited this criteria may be, we can identify some major issue why put in question the diagnosis. First of all, the PaO2, FaO2, indeed is not constant across a range of FaO2. And there is a specific response depending upon the different ventilator setting and PEEP. One of the most interesting paper, to my knowledge, just to represent these difficult identification of the ARDS, is represented by the paper that has been published in 2007 by Jesus Villar. In this paper, he made a distinction of the ARDS, acute lung injury, acute respiratory failure in general. And interestingly, starting from the situation where on day 0, the FeO2 was 0.5 and PEEP above 5, the number of ARDS were 163. But just the same day, changing the ventilatory pattern and following the definitions that were established by the American Consensus Conference, the real number of ARDS changed. So strictly dependent on how you ventilate your patient. And on top of that, after one day, the setting of the ventilator have changed the pattern as well, and indeed also the number of ARDS changed after 24 hours, and again, changing the pattern of ventilator, the number still was indeed even more reduced. So this is something that we should keep in mind, and often we overestimate the incidence of ARDS basing upon this criterion and not making some, at least adjustment of the ventilator. And this implies also that there will be a different estimation of the mortality. with some misclassification. What's about the chest X-ray, which is still part of the new definitions? That indeed it's unfortunately related also to a sort of inter-observer reliability, that indeed looking at the literature is only moderate even when it is applied by expert. And in the old definition, wedge pressure was mentioned as a way to distinguish patients whose edema was related to the cardiac failure to those who indeed had a lesional edema. But also in these cases, the reason why we may have elevated or not wedge pressure may relate to different causes, including our intervention with a fluid overload. Sorry. For what concerns the diffuse alveolar damage, maybe there's a reasonable sensitivity and specificity, but as mentioned, indeed, this cannot be the way in which we can easily make the diagnosis. However, looking at this limitation, we had personal perceptions concerning what is severe and what is not, and often the RDS, because of that, is under-recognized, especially when we refer to the less severe cases. No doubt that there are specific recognized risk factors, and what these factors lead to is the diffuse pulmonary inflammation, as well as the alteration of the vascular permeability and loss of aerated tissues. And in all these cases, the presence of bilateral opacities is a hallmark. Indeed, histologically, we know that the floating alveoli, the presence of the deposition of proteins with the hyaline membrane and all the other histological alteration as consequences, the alteration of the venous admixture together with the compliance and the diffusion of the process. Then at the end, we led to the new definition that was created and published in 2012, and where there were some differences with respect to the old ones, where timing was for the first time defined a little bit better, just having a time frame of 1 week for the insult and the clinical appearance of the syndrome. The chest imaging addressed bilateral opacities, but not just identifying the right number of opacities that could just characterize the syndrome. And the edema, in this case, exclude other forms of determination and measurement of wedge pressure, and look at more generical and open to the different systems for determining it, the exclusion of the increased hydrostatic pressure that causes the edema. Finally, the PaO2, VO2, together with the similar level of PEEP, delineated the category, the severity category. However, during the meetings of the task forces that at the end produced this new definition, a number of different parameters has been taken into account. For instance, just to address some of those, the presence of the minimal requirement FiO2 at the end, the reason why it was not included, the fact that it is less feasible when you give a specific mandate for the ventilator sexting, or for what concerns the imaging, despite the fact that nowadays the thoracic computed tomography is quite diffused, nonetheless, this may be unfeasible, at least in certain contexts. Or the number of opacities, because in the past, we stressed several times that 3 or 4 quadrants may be necessary for the diagnosis. But indeed, looking at the different literature, there was a poor reliability of 2 respect to 3 or 4, or other forms for addressing the edema, like the electrical impedance tomography, are not feasible. The same is true for other means to identify the extravascular lung water, that because this is not always feasible, not always can distinguish hydrostatic from inflammatory edema, or when we use some markers, like the IL-6, can be quite specific, and not always practical at the bedside in all the different contexts. I will allude to a little bit more to the genetic markers, but for what concerns the pulmonary mechanics, after having explored the different opportunities for integrating the basic values, at the end, we concluded that they were not, they did not improve the predictive validity. If we look at the genetic predisposition of ARDS, a number of studies has been published so far with different propositions and ideas. I do not want to insist that much on that, but giving you the concept that it is not as any specific markers or a genetical pattern, but a network of the different characteristics that combining together may delineate a major risk factor. But again, just with a translational mentality, coming from the lab to the bedside with these concepts is never easy. However, the new definition has been validated on a large clinical database, and indeed the increased mortality rate well corresponded, as well as the longer duration of mechanical ventilation, to the increase of severity. The group of Andres Esteban has made the attempt in a post-mortem biopsies to delineate the correspondence to the severity of the histological picture to the definition of ARDS. At the end, a large majority of these patients who underwent after the death the pathological examination, there were more than 300, and 40% of them were identified based upon the clinical criteria as moderate ARDS, 46% as severe ARDS. At the end, despite the fact that the sensitivity and specificity were quite good, one message is there, that looking at the distribution histological of different diagnoses respect to the diffuse alveolar damage, you can still identify that having as a gold standard the diffuse alveolar damage, even in the category of severe ARDS, there are still other situations like the pneumonia or the absence of pulmonary lesion that were indeed recognized as ARDS in the clinical setting. Indeed, the conclusion of these new definitions were put in question by other researchers, where in a large population at the end were totally unable to find the capability to predict mortality also for the most severe categories. So in summary, indeed I believe that the prediction of ARDS may be still difficult. I do hope, and I think that it will be that way, that the following speakers may open a few windows on new opportunities. However, the clear markers individually usable at the bedside, in my opinion, are not yet available. Others are not feasible. We have alluded to that. And for the moment, we have simple clinical and instrumental parameters that obviously do have limitations, but they are the best we have at the moment. Thank you.